management and collaborate with multidisciplinary team and make a plan for discharge and manage, collaborate with multidisciplinary team and
Good afternoon, all.
आपके नंबर पे OTP आया है.
Good afternoon, Shaukat.
Master.
Smita ma'am,
Yeah.
can we start? Dr. Roy is here now,
Okay.
and the Poonam ma'am is here, and we are waiting for Manju ma'am.
Yeah. She is joining shortly.
Okay.
Nama. Bye, baby. Bye. Love you, baby. Come, mommy. Mommy, what about?
Hello.
Yeah.
Providing care to the bedridden patient.
Uh, Smita ma'am, again, good evening, good afternoon. So we are going to start. As everyone know, we are on live in YouTube also.
Okay.
So rest of them you can join. Those who are waiting list, those who are friends are waiting in the waiting list, they can join through YouTube. And so yeah,
Should I start?
hand over to Smita ma'am.
Okay. Thank you, Shaukat. And a very good afternoon to everyone. And welcome to World Stroke Day observation by Indian Society of Emergency and Cardiac Nurses. As we all know that cerebrovascular accident or stroke has been and continues to be the widespread disease worldwide. And it is currently the single largest cause of disability and second largest cause of death globally. World Stroke Day was established in the year 2004 at World Stroke Congress in Vancouver, Canada. And since then, World Stroke Day is observed on every year on 29th of October. And it is done to build and sustain and to have a more sustained approach towards public awareness of stroke recognition, prevention, and treatment. And as we all know that awareness is the first step towards change. And that is the reason why Indian Society of Emergency and Cardiac Nurses took an initiative to observe this World Stroke Day in order to make a change or bring a change in the patient care and improve, improve the care of patient after stroke. With this, I would request Dr. Poonam Joshi to give the welcome address. Thank you so much.
Thank you, Ms. Smita. Warm greetings to all from Indian Society of Emergency and Cardiac Nurses. Our Honorable Chief Guest, Dr. Roy K. George, National President, TNAI. Other experts of the day, Dr. Manju Dandapani, who is working as an Associate Professor in 9 PGI Chandigarh. Ms. Bensi E. Burgess, Clinical Stroke Nurse Specialist, Ireland. Mr. Unni Krishnan, who is from Max. Dear organizers and dear delegates. On behalf of Indian Society of Emergency and Cardiac Nurses, I welcome you all to this program, which is an online webinar on Stroke Day being celebrated on 29th October 2021. Before we start, I would like to tell you a little bit about our society. Our society takes a pride of being the first of its kind in the country, representing trained emergency and cardiac nurses, because we believe that nurses and the elite health professionals, they play a very decisive role in emergency and cardiac care. And as nurses, being the important member of healthcare team, we have to play an important role in identifying and managing the stroke, as well as educating the general public and bringing awareness among them. So today, on this occasion, we have Honorable Chief Guest with us, as well as we have the experts. I once again welcome you all. And it's been said that when somebody has a stroke, the stroke could be in the hospital or in a house or at home. So every second that goes by is very crucial. And as nurses, we have to be very, very careful, and we have to play a very crucial role in identification and management of stroke. So ISCN takes the opportunity to raise the awareness among the nursing personnel about the stroke and the high rates of stroke that are existing. And we have experts with us, and I wish you all the very best and wish you good learning. Thank you. Over to Ms. Smita.
Thank you, ma'am. Now I would like to welcome Dr. Roy George. It's my proud privilege to introduce him. He is the President, Trained Nurses Association of India, and presently he's working as professor and principal at BMH NIMHANS, Bangalore. He has done his master's in psychiatry nursing from NIMHANS, done his PhD from School of Behavioral Sciences, Mahatma Gandhi University, chief editor of Kerala Nursing Forum, first journal of nursing from Kerala. He has a research interest in dementia and old age. He has many publications in national and international journal, and he has been an author of professional books. Thank you so much, sir, for taking out time for us and enlightening our participants with the pearls of wisdom that you have. I request you, sir, to inaugurate the session. Over to you, sir.
Thank you, Smita, for that introduction, and good afternoon to organizers of the conference, the office bearers of Indian Society of Emergency and Cardiac Nurses, and all participants. It is a real pleasure and proud privilege to be here on this World Stroke Day, among with all of you who are trying to highlight the importance of the day and the major role the nurses have to play in prevention as well as early treatment and rehabilitation of cerebrovascular accidents. Traditionally, cardiac attack or heart attack was getting a lot of importance or public attention, whereas an almost or more severe attack, the brain attacks are not seen that seriously or many times neglected, which happened in a long home to hospital or door to door time, and where the patients, in spite of many treatments, modern treatments available, patients get affected with severe effects of a stroke, which could not be treated well. So definitely World Stroke Day tries to highlight the importance of early treatment and identification of stroke. And I'm happy to know that Indian Society of Emergency and Cardiac Nurses are taking up this day. And honestly saying, I did not know there's a society called Indian Society of Emergency and Cardiac Nurses. I wish the society all the best. I do not know how, since so many years they have been working. Trained Nurse Association of India, as a professional umbrella organization, always welcomes such initiatives by specialist nurses, people who are interested in special areas or focus groups or interest groups, to highlight each area, because specialization has become the norm of the day and nurses need to move on. I am honest enough to say that initially my four predecessors in former office bearers, many of the office bearers in TNA was little skeptical about so many societies being formed. But the current TNA always welcomes that, because TNA can be a general professional association. Special interest groups or special societies has to be formed in every nook and corner of the professional service and education, because this will announce to the world that nurses are there in each and every part of healthcare. So such societies are always a welcome step, and TNA declares our unconditional support to such initiatives, and we are there to help you and support you so that this will result in updating of nurses about new treatment techniques in stroke, as well as the importance of early care and identification of stroke. Though not a practicing nurse, I'm an educator for the last 35 years. I was lucky enough to identify stroke in two of my friends on a evening, because they just discussed something which is not very relevant, or just suddenly forgot some of my friend's name, and then I just tested his sensation, and there was some abnormality. I rushed him to hospital, and I could prevent a serious stroke in him, because the treatment techniques are so easily available. So for the public also, it's very important that nurses also get very updated, strongly updated about this thing. So such initiatives are always welcome, and I wish the organizers all the best, and request the participants to make the best of the day the information which you will get. And one correction, I am not working in NIMHANS. That is, I studied did my MSc in NIMHANS way back in 92. I left NIMHANS in 92. And I am presently working in Kerala in Baby Memorial Hospital as the academic director of the academic institutions, and also as principal of the College of Nursing. It is no issues. I just want, because some people shall not misinterpret that I am from Kerala. Sports Trainers Association head office is in Delhi, and I hip hop between Delhi. Tomorrow also evening I am coming to Delhi. So thank you very much for this proud moment, for giving me an opportunity to inaugurate this World Stroke Day program of the Indian Society of Emergency and Cardiac Nurses. Once again, thank you and all the best. Thank you very much. With these words, I declare that the event is open and inaugurated. Thank you very much.
Thank you so much, sir. I'm sorry for those mistakes that we did. Now I would request Mr. Shaukat Ali. He is the president of Indian Society of Emergency and Cardiac Nurses, and he's one of the very important member of the team, and he's very hardworking and very intelligent person. Over to you, Shaukat, for the presidential address.
Thank you, Smita ma'am, for overwhelming introduction for me. Welcome to all for this great event, that is World Stroke Day. As you know, stroke is very as a pandemic in developing countries now, and the treatment of stroke is something like in emergency, it is a neglected area of stroke protocol or stroke treatment in developing countries. That's why Indian Society of Emergency and Cardiac Nurses like to enlighten this day with a webinar. As you know, we have this webinar in Facebook and YouTube. So what is why Indian Society of Emergency and Cardiac Nurses working in the emergency and cardiac space? That is very important question that I have to answer in this time. As you know, Dr. Roy said well that knowledge is very important, and more than that, Dr. Roy is here, so I would like to add something more. The integration of knowledge with clinical skill is very important more than getting knowledge, especially those who are working in the emergency areas, like what we can say this fast track areas, where we have to be quick and fast with good knowledge. For this integration, Indian Society of Emergency and Cardiac Nurses, this a group of people, group of nurses to commit for the nursing society and community to develop skills and knowledge for this special our community. So as you know, we have number of good clinicians and we have number of good academicians. So integrating these clinicians and academicians will work and will benefit more for the patients and nurses. That's the motto of Indian Society of Emergency and Cardiac Nurses. And we have been working in India as a registered society since 2019, and we are collaborating with a number of institutes in India like SMS Jaipur, Subharati College, and the community spaces of northern districts of Kerala, and MM College, Punjab, and other Guwahati Medical College, and Arunachal Pradesh School of Nursing. So by this collaboration and integration, we want to take this thing into the peripheries of India. It will help to get better care for those who needed care in the peripheries. That is the main motto of this society. And as everyone know, in developing countries, emergency care is very important. As everyone knows, like India, the number of doctors is very less, and the ratio of doctors as nurses, doctors and patient is very less. And in the peripheries, there is no doctor want to work in the peripheries, like in PHSCs. It is maybe due to they are not getting good salary, maybe due to they are not getting any facilities. But everywhere we were there, the nurses are there. So the capability of taking care of emergencies should be enhanced for nurses rather than focusing other specialties. You can see when India started the maternal health care program about 1915-16, in the year of 90 to 2000. So what was the aim? Who take that maternal health child program? That is taken by nurses only. Like that, the emergency care also should be taken by nurses in India, and we have to establish all the emergency care protocols to the peripheries, and we have to focus all the clinical nurses and those who are working the academics, and these should be focused to train. That is the motto of this society. And as we know, we have good speakers today, and we have a number of number of good experts here. So I am not extending much as a presidential address. I am handovering to Smita ma'am. Thank you, everyone.
Thank you, Shaukat. Thank you for those words that you have told about ISCN. And with that, it's time now to unveil the theme. And for this, I would like to introduce someone who doesn't need any introductions. She's a very eminent personality in nursing, and I'm proud to say that she is my senior. So, Dr. Manju Dandapani. Welcome, ma'am. And I would like to tell a few words about her. She is presently working as Associate Professor at PGMER, and she is Secretary of Society of Indian Neurosciences Nurses. She has done her baccalaureate and master's from All India Institute of Medical Sciences. She's an MA in sociology, and she has done her PhD from INC Consortium. She has a very rich experience of working in various good institutes like AIIMS New Delhi, PIMS Pondicherry, and JIPMER Pondicherry. She has a huge achievements that she has done. I have just highlighted few, but she has number of achievements. She's globally selected among the 100 nurses of women in global health in collaboration with the WHO. She has won the award of best publication. She and Best Poster Award from the Society of Rural Mental Health 2021. She is also selected as the Best Neuro Nurse Award in 2012. She has the Best Paper Award in NSI for both the years 2012 and 13. She has number of publications in Index Journal, national and international. She's an editor and reviewer in various journals and speaker in various national and international.
I think I told you something.
So with that, ma'am, I would request you to unveil the theme for today's World Stroke Day. Over to you, ma'am.
Thank you, Smita. Am I audible?
Yes, ma'am, you're audible.
Yeah. Unfortunately, I'm not able to join through my system, so I'm joining it through my phone. First of all, I would like to thank the entire team, that is Society of Emergency and Cardiac Nurses, President Mr. Shaukat Ali, and thank you so much for inviting me for the theme of the Stroke Day. So we know that stroke is the second leading cause of death, and even at 400 people lakh every year suffering from stroke, and 80 million worldwide are the stroke survivors. WHO data says that even 1.85 million people are likely to suffer stroke in coming year. So we know that many stroke survivors are facing significant challenges, including high mortality, high morbidity, which becomes a burden to the family as well as to the society and to the nation and to the globe. So World Stroke Organization observes a World Stroke Day every October 29th to enhance the education of public education regarding the stroke and stroke identification, and to enhance the quality treatment and quality services towards comprehensive stroke care. So the target of observing this World Stroke Day is towards public as well as to policy makers and to authorities. So to unveil the theme, I'll just share my screen. Just a minute. Yeah, so as I told, the purpose of World Stroke Day observation is to raise awareness of the signs of stroke among the public and the need for timely access to quality treatment and care. So the the theme of this year's World Stroke Day is precious time. Minutes can save life, because we know that time is brain. Minutes can save lives. Minutes can save memories. Minutes can save mobility. Minutes can save speech, and minutes can save independence. So these all are the areas where the stroke patients face disability and morbidity, which really affects their activities of daily living and which make them dependent towards their family on their family members, and give a lot of challenges to the patient and family itself. So we know that, so this is this year's stroke theme says, learn the sign, say it's a stroke, and save precious time. So to learn the sign, they have also provided a kit or a poster to simply make the public understand about FAST, which help us to early identify the signs of stroke, that is, they are face drooping, arm weakness, and speech difficulties, and to know the importance of time and to rush to the emergency stroke care services, not to any hospital, but wherever stroke facility is available. So as soon as we identify, affirm that it is stroke, and rush to the emergency. Why do you say that time is brain? Because we know that whenever there is an obstruction due to a thrombus or emboli or due to hemorrhage, when the vascular supply to the brain is affected, a part of the brain gets ischemic, and surrounding that, a part is getting getting lack of oxygen and lacking oxygenation. That particular area is salvageable if we timely remove the clot or break the clot. That area is known as penumbra. So that particular time within which we can break the clot is 3.5 to 4.5 hours. And within that time, that particular time duration is known as window period, and within which we need to actively start thrombolysis in this patient. That's why we always say time is brain, because whenever there is a ischemia, what happens, there are around 19 millions of neurons are lost, and 1.9 kilometers of nerve fibers are being damaged, and 12 millions of synapses are lost. And we know that brain only depends on glucose for its energy production, glucose and oxygen. So we need to provide continuous blood supply, blood flow to the brain. Brain doesn't have any glucose storage or glycogen storage for generating glucose. And we also know that we know that 2.5 brain is just 2.5% of the body weight, but 20% of the blood supply goes to brain, because 25% of the body metabolism happens in brain, because you know that brain is master organ which is regulating each and every small to big activity in our body. So it is our responsibility to immediately revascularize the patient by breaking the clot. That's why we say time is brain. So this awareness has to be generated among the public, and that is the main theme of this year's World Stroke Day. So when we talk about World Stroke Day, time, it is not only the time matters in emergency management, time matters in every aspect of the stroke care continuum. So if you look at the stroke care continuum, it starts from the prevention, primary prevention, early recognition, emergency medical care, and in-hospital care or ongoing care, and proper rehabilitation and timely reintegration to the community. So when we say about timely prevention, it includes public education, educating the public, school children. So every World Stroke Day in PGI, what we do, we educate the public, we educate the college students, school students, because school children, it is very important for us to educate so that they can early adapt their lifestyle proper, good health lifestyle they can adapt, and remove, or they will not get indulged in unhealthy habits or risk behaviors. So we can prevent stroke only when we prevent risk factors, and when we help them not to adopt risk factors in their lifestyle. So when we educate school children, they can also educate the society, their family members through them. So they are also a medium for us to educate the public. Not only direct education we are giving to the school children, they are also acting as the medium to reach the general public. So we need to identify individuals with risk factors. We need to refer and follow up individuals with risk factors, and timely management of risk factors. It is very, very important. And maintaining compliance for patients people who are having hypertension, diabetes mellitus, smoking, obesity. So timely intervention is very, very important. So everyone who is listening to this sessions today, you all have a huge burden to take on your shoulder to educate your family members, near and dear ones, and colleagues, and everyone related to prevention of risk factor and prevention of stroke among in our community. So you also need to educate them about early identification. So when we talk about, if we educate them in a later stage of life, it will be difficult for them to change their lifestyle. So early preventive measures are very important. So when our next is timely identification. When we talk about timely identification, we all know, all have heard about FAST, that is face weakness, arm weakness, and speech difficulty. And in time, we need to take the patient if we are able to identify this symptom. So it is also modified into BFAST, that is B for balance impairment, and E for eyesight or double vision or fixed gait or lateral gaze. And next, the same we had in PJ, we had converted to Hindi for Hindi population. So that is Bachav, B for Baju, that is Kamzori, in heart mein jo kamzori hai, like arm weakness, and Chehra, that is facial drooping, and Avaz, that is a speech, and Waqt, that is time. So Bachav is really a meaningful and apt term we got for fast in Hindi. So next is after timely identification, timely transportation. So we know that in India, when we talk about transportation, roads, ambulance services, and emergency pre-hospital care team, everything is in infancy stage, or it is coming up. But we know that a lot of lacunae as compared to Western and developed countries. So appropriate mode of ambulance service need to be used. And once the patient comes to reaches the emergency, timely emergency management is very important. So 0 minutes, we entry to door. So 10 minutes, patient is assessed and confirmed to have stroke, because you know that stroke is a clinical diagnosis not based on any investigation. Then 15 minutes, stroke team is activated. 25 minutes, CT is done. 45 minutes, CT is interpreted. And 60 minutes, door to needle time, that is thrombolysis, is given to the patient. But in our hospital, with the introduction of stroke nurses, we achieve this target of door to needle time in 45 minutes. So in timely emergency management, there are certain components we need to know. One is comprehensive stroke care service or stroke care center is very important in management. Then we have to have cord stroke to activate as soon as the patient enters the emergency, so that the cord stroke will activate all stroke team members, which include neurologists, stroke nurse, physiotherapist, neuroradiologist, and they all will be activated, and they will all take their position and reach their targeted place. For example, neurologist and stroke nurse will be reaching the emergencies. Neuroradiologist will be making the imaging facility ready. Then stroke team and stroke nurse play an important role, very, very important role, from assessment to transporting the patient, counseling the relative, assessing the eligibility for thrombolysis, getting the CT done, reading the CT, immediately informing the neurologist, and administering thrombolysis or TPA, and then pre, during, and the intra and post monitoring during thrombolysis. Then stroke kit is an important part. So every stroke nurse in our institute, they are 24/7 on duty. They have a stroke kit which contain all the equipments for early assessment and thrombolysis. Then proper SOP and guidelines should be there, and proper communication and collaboration should be there. I told you about the stroke team. This is our stroke team. Society of Indian Neuroscience Nurses, we have developed a stroke guidelines for acute stroke management. This is the clinical pathway for stroke we follow in PGI. And here you can see that door to needle time, door to CT time, and window period is better or less when we compare when stroke nurse is on duty as compared to the previous time before we implement stroke nursing. So you can see the door to CT time is average is 11.5 minutes. Before that it was 15. Door to needle time 60. Now we have, this is 3 years back data. Now we have improved upon to 45. And before stroke nurses it was 65, and window period 180 and 195 minutes. So this is about the emergency management. You will be having further session on management. I will not go to that aspect. I'm just only telling about importance of time in various continuum of stroke care. So timely ongoing care. So once the patient has undergone thrombectomy or thrombolysis, patient needs to be admitted, but where to be admitted? In emergency, in any ward, in a neuro ward? No, patient needs to be admitted in a stroke unit. It is very important, which is having adequate resources, manpower, stroke nurses and neuro nurses and neurologists, and collaboration with physiotherapists, dietitian, speech therapist. It comprises stroke units so that we can provide timely care to the patient. Stroke nurses guidance and planning care is important. SOP and stroke guidelines and initiation of rehabilitation in all domains. That's very important. Physical rehabilitation, cognitive, neuropsychological rehabilitation, respiratory rehabilitation, sensory rehabilitation. All these aspects are important. Then prevention, early identification, documentation and management of complication. This also have to happen in timely. Otherwise, patient will develop further complication, and timely discharge from hospital and timely caregiver empowerment. Many times after the discharge, patients, caregivers face a lot of problems because they are not educated properly. So timely, before discharge, 3-4 days before itself, we need to start training the caregivers for taking care of the patient at home. And timely follow-up and home care, that includes caregiver education, therapeutic complaints, rehabilitation, follow-up. Maybe rehabilitation can be home-based or institute-based, and proper follow-up and prevention of stroke recurrence. So they have to manage all the risk factors patient had so that they can prevent a secondary stroke. And they have to help the timely integration back to community. Why I am telling timely integration back to community? Once a patient survives stroke, their caregivers believe that even if the patient is improving with physiotherapy and other things, they believe that he is a patient. He's always a patient, so he needs to be provided rest, he needs to be fed, he needs to be assisted in everything. No, you need to encourage and convince the caregivers that they have to be gradually brought back to the family role and the society role and their activities of daily living gradually. So whatever stroke care, rest and other things which were acutely needed are provided, done. Now every day are the caregivers' responsibilities, bringing them back to the previous life and helping them to integrate back to the community. So I have discussed about the aspect of emergency management, every aspect, but timely identification and timely emergency management are the soul of stroke care, I can say, while we provide the entire timely management to the patient. Thank you so much. Thank you once again for giving me this opportunity.
Thank you, ma'am. It's all our pleasure to have you on this platform, ma'am. And you have very beautifully unveiled the theme, that is time is brain. And as ma'am said, that as healthcare professionals, it's our moral duty to educate the general public about how to timely manage and prevent stroke, and also how to timely identify stroke. That is something very, very important. Rest everything is done in the hospital and we are there to help the person. But the general public are unaware of how to identify whether it is stroke. So the sooner they identify that it is stroke, the sooner the management can be done. And that is what ma'am has beautifully explained. And ma'am, we are very excited about whatever the excellent work that you are doing at PGI Chandigarh. If anybody has any questions or any questions they want to ask Dr. Manju for knowing more about what is happening at PGI Chandigarh, how are they managing patients of stroke, and how did they manage reducing the door to needle time so beautifully, like less than 60 minutes. That is really commendable, ma'am. Because the AHA says it should be less than 60 or 60, but you have done it, even much better than that. So, which is like really commendable, ma'am. So, would you like to put some light on that? I mean, like, how did you manage doing it?
Yeah, I can say that. Am I audible?
Yes, ma'am, you
So
are.
here, like asanas, like in a Western setting or developed country, if we say in the hospital, they already get the information that a patient is going to come, right? But in our setting, it is very rarely that happens. The patients already inform us, and in emergency setting, we are ready with everything to receive the patient. So most of the time, we only come to know when the patient enters the hospital. So when the patient enters the emergency department, emergency room, like there won't be any neurologist exactly, there won't be any stroke nurse. It would be the physician, general physician who are in emergency room, and the general nurse. So as soon as the physician identify that, assess and identify that it's a stroke, that to identify anterior circulation stroke, it is all about fast. If it is a posterior circulation stroke, there will be consciousness, loss of consciousness, and respiratory difficulty, and all those. But in anterior, it's all about the left or right, frontal lobe and parietal lobe, which is getting affected. And most commonly, that this middle cerebral artery that is getting affected, that is getting blocked. So mainly it affects the right or left hemisphere of the brain. So that doesn't result in any respiratory difficulty or a loss of consciousness until if the patient comes very late because of increased edema and increased diabetes. So the patient comes in time, the patient will only have that symptoms of heart. They will be having either facial drooping, speech difficulty, and weakness of varying degree in either of the side of the bone. So this is a clinical diagnosis. Now we know that patient is having stroke. We don't need any investigation to diagnose this patient. So like we need to get a CT scan, but to prove that it's not a hemorrhagic stroke, it's only a ischemic stroke. Because that once we diagnose a hemorrhagic stroke, the management goes altogether in the opposite direction or in a different. So we cannot definitely give thrombolysis to a patient who's having hemorrhagic stroke. So we need to get a CT scan done. So as soon as this clinical diagnosis is made by the physician and emergency, they activate the cord stroke. So everyone in the team get the information in their phone, and immediately the neuro nurse and the neurologist come to the emergency. The neuroradiologist will make the CT facility free, and will get ready for a CT angiography. So as soon as the neurologist and neuro nurse comes there, they start assessing the patient. Already the general ABC must have been managed already. So however, they redo it, they do a NIHSS score and assess the severity of the stroke, and immediately they shift the patient for CT scan. So stroke nurse here play a major. So even while shifting the patient to the CT scan room, the nurse will be assessing the patient's eligibility for a thrombolysis and collecting history from the relative and the patient, and also convincing and taking consent from the relative, and monitoring the the PT, monitoring blood sugar, vitals, from emergency to CT. There is a kind of no time lagging between emergency, lot of assessment is going on. No, emergency, as they know, they have cut off, like they have to see the blood ABC, and they have to show the blood sugar, PT, and then NIHSS maybe on the way, and then they will be reaching by the time CT. So the CT is done fast, CT is read fast, and if the patient is and the thrombolysis assessment, indication assessment is being done, eligibility criteria, and once the neurologist make the decision, and even the neuro nurse itself is quite eligible to, they are capable of reading the CT and aspect score, and they communicate to the neurologist, or neurologist are already there, and they make the decision to thrombolyze the patient. So we can immediately thrombolyze the patient, and they also further coordinate the CT angiography. And if the patient is late, coming late, they further proceed for a mechanical thrombectomy if the patient is eligible for that. So these are the main function of the nurse in the stroke care. And they have a stroke kit, as I was telling, they have a stroke kit which have all the facility for thrombolysis, a small saturation probe and glucometer and all those things, whatever for the assessment, and NIHSS scale and complete patient's pro forma for filling. So there is no time delay in any of this. And once the patient gets admitted, what happens, like the stroke nurse will be every day visiting the patient, and with the nurses in the ward, she will be planning the care, coordinating the speech therapist, physiotherapist, and all those things. And the care goes on. And another thing what we have is, as I was telling, that even post-discharge, they face a lot of challenges. We have stroke support group. Past 2 years, we could not do it. Otherwise, we organize every year stroke support group where we invite patients and the caregivers. So they share their experience and they tell how they overcome, they have overcome the challenges what they have faced. So it's really helpful for them to overcome their challenges and help other patients also to get motivated. And so this is how we are managing.
Thank you. Thank you so much, ma'am. And I hope everyone attending this presentation, this webinar will definitely, benefit from the important points that you have highlighted. Thank you so much, ma'am. Thank you. Thank you so much.
Smita ma'am, let me ask something to ma'am. I'm very happy to hear that just like one of the biggest public hospital in India, they are doing well in the stroke time, that dot to needle time. So do you think, ma'am, there is a need of stroke nurse in emergency as a specialty? Calling from the neurology ward and coming to emergency, it may just like AIMS and PGI like institute may trigger the problems. So it is better to take that specified specialist nurses, those are stroke nurses, into the emergency, and they will be posted in the emergency and they will do the work in the emergency. If stroke comes, they will involve their care. Do you think that is something?
Yeah, yes. Thank you for that question. Actually, so we have in our setting 4 stroke nurses. They are dedicated for stroke nurses. They are they're actually to be present in emergency. So sometime they may be taking rounds in ward. That's all. Most of the time they are in emergency. Wherever they are, they will come in emergency. That's all. Otherwise, they are dedicated stroke nurse. We have in PGI that. But I wonder many of the previous premier institute why they are not starting this initiative. So that has to be started. And we have in Society of Indian Neurosciences, we have started a stroke certificate course of short duration, which consists of 10 modules. So if anyone is interested, they can undergo that course, and which will help us. And now DGHS also has collaborated with us in organizing that. Maybe gradually stroke nursing should come as a specialization. So I feel that whatever specialized courses that we are doing, like cardio, sometimes there are cardio. So many people will be there as cardio. So in managing myocardial infarction, heart failure. So various aspects, these specialized nurses should be given some particular care, and their potential should be fully utilized. So we also have a neurosurgery nurse counselor. They are mainly for the the patients who are coming for the follow-up and getting discharged, to counsel them and empower them. So we have a neurosurgery nurse counselor. So we are trying to utilize the specialized nurses in various roles. And we have, last year we had, orthopedic nursing over here. So the nurses were passed out. One of the nurses was an in-service candidate who will be working here. So she is now functioning as a amputation nurse, actually, amputation nurse. So the proper the placement is not done because she's just fresh passed out. So, but we are trying to bring in amputation nursing services also here in PG, because we have an amputation place. So this specialized role of nurses should really be utilized, because they have a lot of potential. They have to be utilized, but in India, unfortunately, maybe in future we may see that.
Don't wait for the last minute. Always try to be the
first. They are able to manage it. The moment whatever they are doing, they will leave that and then go to the emergency patient.
Good.
One last question, ma'am. Time. What do you think the community is? What about the community? They are knowing regarding stroke in this era, or they are same as the last decades, like the stroke always like a devil's things? And
it happens when we get many patients who comes very late, like what do you call in North India, like Smita, you may be knowing, they undergo this kind of tantric, some kind of treatment they undergo, and later they that after that there is no, we are also not left out with any treatment. We cannot not provide any kind of treatment if they come late. They go to this kind of some kind of naturopathy is there. some kind of, what is, Smita, do you have any idea? They do some kind of, spiritual kind of treatment.
Yeah,
And
today only I was
stuck there, and many patients come to us like that. Very, very less, because public awareness is very less. So we are
exactly.
trying to enhance every stroke week and other things.
There are, people are so much into all these complementary medicine, though, complementary medicine does help, but we still do not know how effective it is. I'm not very sure of what we are doing, what you are doing in PGI Chandika, but in AIIMS, it's not. It's only in RML that we have Ayush and all those things. And this, these people are so much. They believe so much in all those things that they believe that if they go ahead doing all these, naturopathy treatment, it will be treated.
And massaging,
massaging and all those things. So they delay their treatment. So that is why, it is very important as healthcare professionals that we tell them that you have to identify it timely and then get it treated timely. That is something very, very important that we need to tell them.
Because it has a hemiparesis as a symptom, they think that a massaging will help them to improve this time. And some kind of nature, like even marijuana, like plants are very common out here in North India, Punjab line especially. So they use that plant and do something, they go to some kind of source. I forgot, there's something in Hindi which we often use today. I'm not able to recollect that word. So all these things delay the emergency management. So we need to really educate. So that's what I told. We always, every year we target our school students. Nearby 1 or 2 school, we go and educate the children. Like at least they will be a medium for reaching to the public. So I think definitely there is improvement. When in transport, everything, there is improvement over the time. Hope that nurses will be able to do much more to contribute towards the society, especially the role of specialized nurses are like much more, right?
Thank you, ma'am. Yes, role of specialized nurses is really important. People are realizing it, but they haven't realized it fully. So
authorities are not taking.
Yeah. So thank you so much for those enlightening words, and thank you for taking out time, and it was really lovely chatting with you, ma'am. With this, we will move forward with our today's session. Ma'am, I would request you to stop sharing your screen, please. Yeah, thank you so much, ma'am. So our next session is, now I would like to welcome Miss Bincy E. Verghese. She is a clinical nurse specialist, stroke care in Ireland. She has done her BSc nursing from Rajiv Gandhi University of Health Sciences, Karnataka, India, and she has a lot of certifications. She has been a stroke. She has done her course on stroke rehabilitation. She's done her postgraduate diploma in gerontological nursing in 2019. She's master's in stroke care, and she has done her nurse prescribing course in 2012. She has worked in a number of places. She has worked in Bombay Hospital and Research Center, Mumbai, and she's presently working in Ireland as a clinical nurse specialist. We are really happy to have you here, Bincy, and Bincy will be speaking on Door to Safe Hand, a stroke nurse in ER. Over to you, Bincy. We are waiting to hear to you.
Thank you, Smita.
You can start sharing your screen.
Yeah, can you see my screen?
We can see you, but not your shared screen. Have you shared your screen? Yeah, we can see it now.
Yeah, thank you. Good afternoon, everyone. My name is Bincy E. Verghese. I am working as a clinical nurse specialist for stroke care in Tipperary University Hospital, Ireland. Thank you so much for the organizers of ICCN for inviting me to speak on the webinar for World Stroke Day. Precious time was the theme of World Stroke Day 2021, which aims to raise the awareness of stroke signs and symptoms and benefits the timely access to emergency medical care. Today, my topic is Door to Safe Hands, role of stroke nurse in emergency department. As you know, stroke is one of the leading causes of death and disability worldwide. Globally, 15 million people are affected by stroke every year, with 5 million people experiencing permanently disabled. Strokes are classified as two types, ischemic and hemorrhagic stroke. Ischemic stroke occurs due to the blockage or interruption of blood supply to the brain, whereas hemorrhagic stroke occurs due to the rupture of blood vessels in the brain. Around 80 to 90% of strokes are ischemic and 10 to 20% are hemorrhagic. I just want to tell you the definition of the stroke according to World Health Organization. It's a neurological deficit of sudden onset with the focal dysfunction of a non-traumatic vascular origin lasting for longer than 24 hours. If it is less than 24 hours, only the symptoms, that is TIA or transient ischemic attack. Damage to part of the brain caused by an interruption in its blood supply, either a blockage or bleeding from one of the arteries supplying to the brain. Affected part no longer functions normally. So we will call it as brain attack. When stroke strikes in emergency department, how fast is fast enough? F stands for face, A for arm, S speech, T for time to act. How fast is fast enough in the emergency department? As everyone knows that stroke is a medical emergency. Time is brain. Even every second matters after a stroke. Around 1.9 millions of neurons are lost every minute after an attack of a stroke. From the moment a person starts to experience the stroke symptoms, the clock starts ticking. Please keep that in mind. 1.9 millions of neurons are lost every minute. So, every minute that passes following a stroke can make a huge difference in terms of how well their brain, arms, legs, mobility, speech, or cognition may recover. According to the American Heart Association guidelines, we have to remember some of the key numbers. First is the 90%. As I said in the beginning, 80 to 90% of the strokes are ischemic strokes. So they might be potential candidates for clot-busting therapy or thrombolysis if they get into the hospital in time. Then you have to remember 999 or 112. I think in India it's 911, as Manju ma'am said earlier. Here we call 999 or 112. Call immediately someone experiencing the symptoms of stroke. If you think if a person is showing a signs and symptoms of a stroke in the community, the time to call the emergency number. Okay, so then you have to bring the patient down into the stroke center. The next key number is 4.5 hours. That is the maximum, the window of opportunity to thrombolyze the patient, to reverse the brain tissue damage. That's a maximum window of time from the time of onset of the stroke symptoms. Maximum time window is 4.5 hours. Then, as I said earlier, 1.9 million neurons lost each minute. So earlier the treatment, the better the outcome. Then 60 minutes. 60 minutes is the door to needle time. When the patient come into the emergency department, from that the time to thrombolyze. We have to thrombolyze the patient within the 60 minutes. So please remember these key numbers. 90% are ischemic strokes, so they can be a potential candidate for thrombolysis. Then ring the emergency number if you see like patient is experiencing symptoms of stroke. Then maximum window of opportunity is 4.5 hours. 1.9 millions of neurons lost every minute. Then door to needle time is 60 minutes. Our aim is to the target door to CT scan time is less than 20 minutes. Here we are doing door to CTs within 20 minutes, and also our door to decision time is within 30 minutes. It is the patient is for thrombolysis or thrombectomy. So I know the most of our audience are nurses. So all of our nurses, all of staff should be familiar with the FAST sign to facilitate the recognition of the acute stroke. If maybe you're working in an emergency department or the wards, if one of the patient is showing the stroke symptoms, you must able to, recognize the symptoms. F for facial weakness. You'll ask the patient to smile. Then if you think is any facial deviation or facial weakness, then A, arm for arm weakness. A for arm weakness. That means you ask the patient to raise their arm. They're not able to lift it up. Then speech. S for speech. Patient speech can be slurred or the speech, they're unable to speak. They might have expressive dysphasia. Then T is the time to alert the stroke code. When a patient arrives in the emergency department with an acute stroke, the ED staff must immediately activate the stroke code. So I just want to show you the pathway, what we are following here in our hospital. If the nurse recognizes that it's a FAST positive, any of the symptoms shows it's a FAST positive, the nurse will alert the stroke code. In the stroke code, once they alert the stroke code, the stroke team include the consultant, medical registrar, stroke nurse specialist, and they will inform the CT department as well. Then once the nurse activates the stroke code, she will start to do the observations like the vital signs, neuro-obs, and the time of confirm the time of onset of stroke. What time this stroke symptom started, because we just want to know if the patient is a candidate for thrombolysis. Then insert a 18 gauge IV cannula, send the urgent bloods to the lab, then alert the lab for urgent bloods. Then once the stroke team, once they come, they will do the clinical assessment and they will do the NHS score. Then we will book a FAST positive CT brain in the NIMS. NIMS is a National Integrated Medical Imaging System. We are booking all the CT brain and CT angio all in the NIMS. If the patient NHS score is above 4, patient can be a candidate for thrombolysis. If the NHS score is above 5, patient can be a candidate for thrombectomy. That means patient can be a large vessel occlusion. If the NHS score is above 5, we will book the CT angio, aortic arch to vertex multiphase, and CT perfusion. If it is below 5, we will book only CT brain FAST positive. Why we are booking this CT brain FAST positive is, if you book a normal CT brain, we have to wait the approval from the radiologist. But here, we, already the stroke alert, they will alert the CT department as well. The radiographer will inform the radiologist the FAST positive is coming. So we will book the CT brain FAST positive in the NIMS. There is no need to wait for the radiology approval. We can get it straight away. Then once the NHS is completed, once book the CT brain or CT angio or CT perfusion, we will escort the patient to the CT department. The nurse should escort the patient to CT department with the stroke team. Once the CT completed, we are going with we have a portable, thrombolysis pack with us. We will thrombolyze the patient. That means we will give the bolus down in the CT department. This is the way we are reducing the door to needle time. Then rest of the infusion for over an hour, we will give it either in the emergent, the ED resus room, or we will give it in the critical care bed. Then if the patient is for thrombectomy, if the patient is having a large vessel occlusion, if that hospital is not a thrombectomy center, we will activate the protocol 37 ambulance to transfer the patient to a thrombectomy center. The protocol 37 ambulance means it is an emergency inter-hospital system. The 100% of the Irish hospitals are access to this protocol 37 ambulance. So we can immediately transfer the patient to the thrombectomy center. Once we already started the thrombolysis, we won't wait to finish the thrombolysis. We will transfer the patient with the thrombolysis accompanied by a nurse and a doctor. Then we will send to the thrombectomy center if the patient is a candidate for thrombectomy. I just want to tell you about the assessment of the acute stroke. We will take the full history and examination, determine the risk factors of stroke. Might be patient is having any atrial fibrillation, diabetic, hypertension, cholesterol, any history of smoking. Then determine the neurological deficit and classify the stroke. Then monitor the blood pressure, heart rate, oxygen saturation, temperature, blood glucose, swallow, and continence. These are the assessments. We will do it in ED. The investigations I told you earlier, the nurse will send the urgent bloods. These urgent bloods include full blood count, urea and electrolytes, glucose, Koyak screen for the INR and PT-PTT, ESR, CRP, then ECG for to detect any arrhythmia or ischemia. Then CT brain fast positive, CT angio, CT perfusion, and chest X-ray. These are the investigations we will do it in the beginning. And the ECG, once the patient come into the ED, there is no need to hold to get the ECG for that patient. For the stroke, until patients are in chest pain, there is no need to take it straight away. We have to do the CT first after the NHSS. Then once come back to the resus room, we will do the ECG. Then what is thrombolysis? Some ischemic strokes are eligible for clot busting drug. The drug aims to disperse the clot and return the blood supply to the brain. The medicine itself is called alteplase or recombinant tissue plasminogen activator. The process of giving this medication is known as thrombolysis. I will tell you some eligibility for TPA. The age should be greater than 18 years. It should be diagnosed as ischemic stroke. That means the CT should exclude there is no hemorrhage. The onset of symptoms should be within 4.5 hours. The license in Europe is up to 3 hours only, but still will give maximum hours 4.5 hours. The stroke symptoms present for at least 30 minutes. The symptoms resolve within 30 minutes. We will not thrombolyze the patient. Then, as I said earlier, the measurable deficit, the NHS score should be greater than 4. Then the dose of the TPA, you'll give the 0.9 mg per kg is the maximum dose is 90 mg. We always give 10% of the total doses given as an initial bolus. Then rest of the 90%, we will give it as an infusion over 1 hour using an infusion pump. So before administering the TPA, the blood pressure monitoring, monitor the blood pressure every 15 minutes. The systolic BP should be less than 180 and the diastolic blood pressure should be less than 105. If the systolic BP is greater than 185 and the diastolic is greater than 105, more than 2 reading 5 minutes apart, we'll usually give labetalol 10 mg IV bolus and at a rate no quicker than 10 mg per minute and maybe repeated once again after 20 to 30 minutes. The monitor the blood pressure every 5 minutes during the labetalol treatment because if the patient can go to some hypotension or bradycardia. So if it's happened, you have to treat with the atropine. Then during and after the thrombolysis, monitor the blood pressure every 15 minutes for first 2 hours. After, once we started this TPA, you have to monitor the blood pressure every 15 minutes for the first 2 hours, then every half an hour for the next 6 hours, then hourly for the next 24 hours. So if the patient was in the emergency department resus room, we will move the patient to the CCU, one of the critical care bed. So first we have to monitor every 15 minutes for the first 2 hours, then half an hour for the 6 hours, then hourly for the next 24 hours. The BP should be strictly controlled in accordance with the guidelines. The nursing staff to call the registrar or consultant if the blood pressure is go above 180, the systolic, and the diastolic above 105. Then you have to monitor a few things for the first 24 hours after the TPA. Blood pressure monitor as per the protocol. ECG monitoring continuously for the 24 hours. Neuro observation like GCS. The nurse the same like monitoring the blood pressure every 15 minutes for the first 2 hours, then half an hour for the 6 hours, then hourly for the rest of the hours for the first 24 hours. Then you have to monitor the oxygen with the pulse oximetry if it should be greater than 95%. Then monitor the hydration and nutrition should be maintained. No antiplatelet drugs like aspirin, no clopidogrel, none for the first 24 hours after the thrombolysis. And we cannot give any anticoagulants for first 24 hours after the thrombolysis. Then repeat the CT brain after 24 hours prior to starting the antiplatelets. And we have to monitor the temperature And we have to treat with the paracetamol if the patient is spiking any temperature. Monitor the blood glucose. It should be maintained below 12. No NG tube, no arterial catheter, no central venous catheter none for the first 24 hours unless absolutely necessary. Then no urinary catheter at least 1 hour after the infusion complete. If you need it, you can put it after an hour, but for the strokes, we won't really encourage to put the urinary catheter. Then no DVT prophylaxis, no Clexane or anything for the first 24 hours. Bed rest, no rehabilitation assessment for the first 24 hours. Patient can be high risk of falls, so you have to do the risk assessment for the falls and keep the prevention measures. Avoid suctioning of the airway if possible. NHS score should be repeated after 2 hours and 24 hours to know the patient prognosis. So just we are going to do the thrombectomy. What is thrombectomy? Thrombectomy is a intra-arterial endovascular therapy. Thrombolysis was the intravascular. This is intra-arterial endovascular therapy. Thrombolysis is the intravenous, which has been developed in order to directly remove the clot from the distal internal carotid or intracranial vessels. A clot retriever device is used. Thrombectomy can be offered up to 24 hours from the time of onset, but time is brief. Each minute lost in the door to thrombectomy process results in loss of a week of functional independence. So door to decision time for thrombectomy, the target time also 30 minutes. So what is the benefit of the thrombectomy is same like the patient with a wake-up stroke. The patient might be went to sleep 10 o'clock at night. We are seeing the morning at 10 or 11 in the morning, patient had a stroke. That's a wake-up stroke. So we always look the time last seen well. The time last seen well the patient is, and within 24 hours, we can send the patient for thrombectomy. So we cannot thrombolyze the patient for the wake-up stroke. So we can do the thrombectomy, but if the patient is having any large vessel occlusion according to the NHS score. Some other things to do. Patients with acute stroke should have their swallow screened within 4 hours of admission. Here, the nurses are certified for doing the swallow screening. That is the not any big swallow screen. It's a basic bedside swallow screening. The nurses should do this swallow screen within 4 hours of admission. And if the swallow screen, if the patient failed, we'll keep the patient nil per orally, and we will refer the patient to the speech and language therapist. And patient might be considered for NG2 within 24 hours. Patient need a feeding, so we will refer to the dietitian, because patient is a high risk of aspiration. So we have to keep the patient nil PO until we do this swallow screening. Then here we usually start aspirin 300 mg for 2 weeks for the acute stroke. But if the patient is thrombolyzed, we will not give up to 24 hours. After 24 hours, the CT scan shows there is no hemorrhage, only we will start aspirin. Otherwise, we will start aspirin 300 mg. So aspirin given within 48 hours of acute ischemic stroke seems to reduce the death and disability. Then ischemic stroke blood pressure management. In acute ischemic stroke, high BP is a response, not a cause. So don't lower it. Only in case of the patient is thrombolysis, we will bring down the blood pressure below 180. But sometimes the patient not be a candidate for thrombolysis. There is no need to bring down the blood pressure down for the ischemic stroke, because blood pressure increases due to the arterial occlusion. It's an effort to perfuse the penumbra. Penumbra is the area that risk of progressing to infarction, but still recoverable if reperfused. So this is the, this blood pressure increases due to trying to perfuse the penumbra. If you bring down the blood pressure straight down, it will worsen the functional outcome of the patient. But the patient is already on antihypertensive medication, we can give it, but we will not start any new antihypertensives in the acute stroke. But after 2 weeks, we will do the blood pressure management with the ACE inhibitors. Thank you so much. Any questions?
Thank you, Binsi, for this lovely presentation. You have very beautifully explained what a nurse should do in the ER to manage a patient with stroke. Is there any questions? If you have any questions, you can put it in the chat box. If anybody has any questions, can put their questions in the chat box.
Good afternoon, Bensi. Could you please little elaborate regarding the pre-hospital care in your system?
Yep.
As we know, India, in developing countries, the pre-hospital care is not developed yet. So what about in Ireland? You are getting these patients after all pre-hospital care and previous assessment was done, or you are getting directly to the emergency department without any pre-hospital care? What is the status in Ireland?
Yeah, here actually once in the community, the patient develops any stroke symptoms, they will call 999. So the advanced paramedics usually attend the scene, and they will assess the patient and they will pre-alert the hospital. And our hospital will get a pre-alert stroke call. So the stroke team will be ready to receive, as I said earlier, the stroke team. So we will ready to receive the patient in front of the emergency department to receive the patient once the once the ambulance comes. So we can once the ambulance comes into the ED, we'll straight away we won't wait for anything. We'll just do we'll get the door to CT time and door to decision time in time.
Yeah, that's great.
Exactly like the AHA tells us to do. It is exactly followed in Ireland.
Yeah.
Yeah.
So our door to decision time is we are trying to get in below 30 minutes. AHA is telling about 60 minutes, but we are trying to get in below 30 minutes door to decision time for door to needle time.
Because your pre-hospital management is really good, because you have good ambulance service which can actually transport the patient immediately to the stroke unit. But in India, it's little difficult. But yes, I was really happy to see PGI Chandigarh doing an excellent job, and they have tried reducing this time, and they have really managed to bring down the door to needle time to less than 60. So that was really commendable. Yeah. Thank you so much. I don't see any questions in the chat box. Thank you so much, Binsi, for this enlightening talk that you have given. We are really glad to have you here. Stay connected to us. Thank you so much.
Thank you, Smita.
There is a question, Binsi.
Yeah.
I have a question. JS Seti, can you please write your question down? JS Seti, if you can hear me, please write your question in the chat box.
Seti, you can unmute yourself.
Yes, you can. Seti, you can unmute yourself and ask the question.
Yeah, she's there. Sorry. You can ask question. Seti, you can ask question if you want.
I don't know. I think she has some network issues, I believe. I think we are.
I will take that question later.
Yeah, we'll take that question later. I would now like to introduce our next speaker for the day. Last but not the least, he is someone who has really impressed me with his excellent CV, Mr. Unni Krishnan SV. He's presently working at Max Hospital. He has done his BSc Nursing from Government College of Nursing, Medical College Campus, Trivandrum. He has done his master's in medical surgical nursing, neurosciences specialty from JIPMER, Pondicherry. He has also done his MBA in hospital administration from Annamalai University. He is certified in simulation by Ladle as a 1 week train the trainer course. He has done a certificate course in clinical trial and clinical research. He's an AHA instructor for BLS and ACLS. He has done emergency neuro life support fellowship from Neurocritical Care Society from UK. He's a stroke fellow. He has done his stroke fellowship, and he is a clean Six Sigma black belt. Unni Krishnan, we are really glad to have you here. And Unni Krishnan will be talking about prevention of strokes. So over to you, Unni Krishnan, and we are waiting to hear to what you have what you have to tell us about prevention of stroke.
Shall I share my screen?
Yeah, please.
Okay, I think Binsi ma'am has to
Binsi,
stop sharing her screen.
I think I have to stop sharing my screen.
Okay, okay.
But I have stopped sharing my screen. Let me just check.
Yeah, now it's okay, ma'am.
Yeah.
So, good evening. First of all, I would like to thank ISCN for giving me this opportunity. Is my sound is audible?
Yes, Unnikrishnan.
Okay.
Yes, it's audible.
So as we know that 29th October, we are celebrating World Stroke Day. We know that stroke is this. It's not. We know that stroke is the second leading cause of death among non-communicable diseases, and every one death from stroke every 3.3 minutes. That means that nearly more 450 deaths per day due to stroke. And in India, a study was conducted by Dr. Jairaj Pandian in CMC Bellu, stating that 1 to 3% of all stroke victims receive treatment, and remaining patients are not receiving the proper treatment. Do you believe that the stroke management in India is good or bad?
I believe it's bad.
Okay. If you are giving in a score of Likert scale of 10, how much you will give? 1 to 10.
Okay, that's a difficult question. See, I'm talking about on the experience that I have. I may be wrong, but then what I feel it is somewhere around. I think it's somewhere around 4 out of 10.
So this year, World Stroke Organization has with the logo of "Minute Can Save the Life."
Yeah.
Right. That means that if you are identifying the warning signs, already Binsi ma'am has given a clear-cut information about the warning signs of stroke and fast and all. At least if the family members are aware about the warning signs, definitely they can bring the patient to the proper hospital and we can initiate the treatment as early as possible. But usually that is not possible in India, but in good centers like North India, we have the AIMS in PGH Chandigarh, and in Rishikesh, they have started the air ambulance services for serving the victims with this type of comorbid conditions, right? So my question is that is stroke preventable and can we manage the stroke? Do you think stroke is preventable?
Some extent it is preventable, I think so.
Okay. Can we manage stroke?
Of course.
So nowadays, due to the advanced technologies in neurointerventional procedures as well as pharmacotherapy, many new drugs are there. We have the good interventional procedure, that means interventional neurology procedures are there to retrieve the blockage, right? In India, 70 to 75% stroke is ischemic stroke and remaining is due to some other reasons. It can be hemorrhagic or it can be due to any RT or any other thing. Usually, if you consider the ischemic versus hemorrhagic, ischemic stroke patients are having good prognosis compared with the hemorrhagic stroke. And the signs and symptoms vary from ischemic to hemorrhagic. Both are different. Main thing is that already Binsi ma'am has given an idea about penumbra, right? The main goal of stroke management is that we have to preserve the penumbra. Penumbra is nothing but it is the area which is surrounded by the ischemic part that is having viability. If you are reperfusing that particular penumbra or if you are protecting that penumbra, definitely the patient will be having minimal disabilities associated with the stroke, and that can lead to improvement in their quality of life. Simple hai, it's written as act fast and save brain. Already ma'am has given the information, time is brain. Time lost, that means that brain is lost. That means 2 million neurons die in each minute until the brain is reperfused. We know the warning signs and symptoms of stroke. I'm not going to discuss in detail. So as per the American Stroke Association 2020 guideline, we have the 7 Ds, that is known as 7 steps to stroke chain of survival and recovery. The first thing is detection, second is dispatch, third is delivery, fourth is door, fifth is data, sixth is decision, and the seventh one is drug. So I will discuss in detail. So first one is detection. If a person is having a stroke in the home itself, if the family members are aware that these are the warning signs of stroke, immediately they can detect this fast sign and they can immediately activate they can immediately inform this information to the ambulance services, right? Nowadays, we are just rather than using the Cincinnati fast scale, we usually use B-fast. B stands for behavioral changes, balance, control, and coordination problem. E for eye abnormality or visual problem. If the patient is having any problem with the optic nerve or any occipital part, definitely they will be having some problem with their visual. The visual disturbances will be there. Following that, facial drooping. Sometimes they will be having problems swallowing. They will be having drooping of saliva. They'll be having weakness in their arms or their extremities. They will be having problem with speech. They can't articulate words properly. And ultimately, we have to call the ambulance service. That is time to call 108. Second is dispatch. Dispatch means once you are informed to the emergency medical team or to the ambulance service, starting from the initial assessment by the EMS technician, there starts the dispatch. That means activation of the emergency medical system. If the patient comes from the home, they can call 108 or to the ambulance service. And sometimes stroke mimics, hypoglycemia can mimic the stroke. So remember, if the patient is in hypoglycemia, immediately they have to treat the hypoglycemia as per the availability of either 5% dextrose, 25% or 50% dextrose. After that, only they can check whether the person, the patient or victim is having warning signs of stroke like B fast or fast. Next is delivery. Delivery means immediately we have to shift the patient to the nearby stroke care hospital or any nearby tertiary care hospital. If possible, at the time of shifting the patient to the hospital, on the arrival time, they can give an intimation to the hospital so that the hospital personnel will be ready to receive the patient in the triage and they can quickly do all the necessary investigation as well as they can ready everything to reduce the disabilities associated with this stroke. That means in the delivery, prompt and rapid transport to the patient to the hospital, pre-arrival information help to reduce door to needle time. Next is door. That means already the patient has received in the emergency department. They have to do the initial triaging, and if anything is, any warning signs of stroke is there, immediately they have to activate the code stroke, or they can pass the information to the stroke team so that they will be ready. And one more thing is that clinically, if any patient is coming to the casualty or triage with warning signs of stroke, from the triaging itself, we can differentiate whether it is ischemic or hemorrhagic. In the ischemic stroke, the patient will be a little bit stable, hemodynamically stable. But if you consider hemorrhagic stroke, definitely they will be having, they are not hemodynamically stable. Sometimes they'll be coming to the casualty with the complaints of seizure, and they'll be a little bit hypotensive and all. Or sometimes, mostly they'll be unresponsive sometimes. Because in the hemorrhagic stroke, what is happening is that already ICP is increasing gradually. So the patient will be showing the clinical signs and symptoms of increased ICP. From the door itself, usually in Indian setting, we will be putting the cannula or peripheral line. Along with that, we'll send all the investigations like BTCT, bleeding time, clotting, that means coagulation profile, renal function test, LFT, lipid profile test along with the CBC and ESR. So that meanwhile, we'll do the other investigation and we'll get the report of all these things. Based on that, we'll get a data whether this person is having proper renal function. We'll get an idea whether the person is having a proper liver function and all. So next is data. That means emergency evaluation and diagnosis of acute stroke. Initial assessment within 5 to 15 minutes. In the initial assessment, we have to do the quick assessment of their level of consciousness. Either we can use AVPU score or we can use the GCS. Usually in Indian setting, emergency setting, we usually use both the scale, either AVPU or GCS. If the patient is unresponsive, then you have to use the GCS. If the patient is little bit conscious, then you can use the AVPU. Then following that, we have to focus on the primary survey. In the primary survey, first we'll move with the airway and breathing. In posterior circulation stroke, there is a chance of problem with airway and breathing. So we have to think regarding ventilation. Whenever we are assessing the airway and breathing, just check the breathing pattern as well as their saturation level. The saturation is dropping below 94%, then we have to think regarding supplementation of oxygenation to the patient as per the standard protocol. Following that, next is circulatory status. In the circulatory status, we have to check the BP. Usually in the acute phase of BP, they will be having a little bit slighter 150 to 180 mm of mercury, and diastolic will be nearly 90 to 100. That is normal. Then we have to check the blood glucose. It should be within the normal range, that is 140 to 180 per deciliter. If the patient glucose is less than 60 mg per deciliter, we have to immediately treat the hypoglycemia. If you are not treating the hypoglycemia, that can lead to further damage to the brain tissue. Then, here, after taking the blood glucose, if we can do the ECG, we can do the ECG so that we'll get an idea whether the person is having any AF or any conduction problem or any other type of arrhythmia. So, atrial flutter can lead to stroke. And assess the stroke by type, severity, location, and we have to check whether it is acute or subacute. Subacute is nothing but it is just like a transient ischemic attack. In the history, we have to ask the time of onset of stroke, progression of symptoms. Then we have to ask whether the person is hypertensive, whether the person is taking alcohol daily, they have any history of smoking, any cardiac diseases. Then we have to ask for any history of trauma, or whenever they are taking the patient to the hospital, whether they have any seizure problems or not. Activity at the time of stroke and stroke severity. So stroke severity.
Unikrishnan, sorry, you just unmute yourself once, okay? Unikrishnan, please unmute yourself.
Hello?
Okay, it's okay. Thank you.
Is it okay now?
Yeah, okay.
So, stroke severity, we usually use the stroke severity assessment scales. Whatever is available in your emergency department, you can use that scale. Many scales are available. Then next is decision and drug. Whenever we are thinking about decision and drug, we have to involve the family members also, because most of the time the patient is vulnerable, they can't take the decision. So the ultimate decision has to be taken care by the family members. So definitely your consultant has to give a proper idea what is the next plan of treatment. Based on that, if they are willing, they can take the treatment in that hospital. If they are not willing, they have to think regarding some other option after giving the primary management to the patient or victim. So here in the decision, based on the CT finding, if it is an hemorrhagic, then it will be move on to the neurosurgery team. If it is an ischemic stroke, definitely we have to think regarding the shifting a patient to the comprehensive stroke unit or stroke ICU so that we can think regarding the further management. In the drug management, we usually use the second generation thrombolytic drugs like recombinant tissue plasminogen activators, or we can use tissue plasminogen activators. Both are a little bit same. And at the time of onset of stroke, starting from the time of onset of stroke, within 3 hours to 4.5 hours, we can think regarding IV recombinant tissue plasminogen activators or IV thrombolysis. Within 3 hours to 4.5 hours, we can think regarding IV thrombolysis. If you are planning for thrombolysis, we should have a inclusion criteria as well as exclusion criteria. That is a standardized criteria that is available in the internet website. Here already Binsi ma'am has given a small description about the inclusion criteria and exclusion criteria, like age should be more than 18 years. They don't have any other renal problem. They didn't undergo any major surgeries within 3 months, like that. So meanwhile, if you are planning to administer the thrombolytic drug, patient should have a proper renal function as well as liver function. If anything is dearranged, then they should be a little bit cautious before administering the thrombolytic drugs. Then coagulation profile has to be checked before the administration of the thrombolytic drugs. As per the AHA criteria, we can start the first dose of thrombolytic therapy in the CT room. But in India, that is not possible. So we will be usually giving the thrombolytic drugs in the ICU itself. Then some literatures are stating that if your triaging system or if your emergency department is having a proper facility to do the transcranial Doppler or extracranial Doppler, based on that, we will get an idea whether the blockage is, whether the ischemia is in the major artery or not. If the ischemia or the blockage is in the major artery, immediately we have to shift the patient to the ICU, and meanwhile we have to alert the neurosurgery team also. So that the main thing is that sometimes we have to move on to the neurointerventional procedures like mechanical thrombectomy or mechanical thrombolysis. Hello?
It's okay.
You can carry on.
So, though the needed time for IV recombinant tissue plasminogen activators is within 60 minutes of hospital arrival. So nowadays we are using the recombinant tissue plasminogen activator Actlase. For thrombolysis, there is a standard calculation is there, that is 0.9 mg per kg body weight. In that, 10% of the drug has to be given as IV bolus, and remaining 90% of the drug has to be given as IV infusion over 30 minutes to 1 hour. That means if the patient body weight is 50 kg, we have to administer 45 mg of this particular thrombolytic drug. The 10% of 45% is 4.5. That 4.5 mg has to be given as IV bolus, and remaining 40.5 mg of the drug has to be given as IV infusion over 1 hour. This 1 hour, in some hospital they'll be giving within 40 minutes, some hospital they'll be giving 30 minutes, or some hospital they'll be giving within 1 hour. So you have to follow your hospital policy and protocol. As per the AHA guideline, within 1 hour we have to give the drug. Then next is mechanical thrombectomy. If the occlusion is in the major vessel, then we can think regarding the mechanical thrombectomy. That means large vessel occlusion, or in fact within 6 hours of symptom onset, mechanical thrombectomy should be considered as the first line of treatment. Then care after mechanical thrombectomy. After the mechanical thrombectomy, we should be a little bit, the nurse should be a little bit alert about proper assessment of the patient in the ICU. So they have to check the hemodynamic status of the patient every 15 minutes for 2 hours, following that 30 minutes for next 6 hours, and 1 hour for next 16 hours. That means for 24 hours, they have to continuously monitor the patient hemodynamic status along with the level of consciousness. If any change in the hemodynamic status, they have to immediately alert the medical team. Following that, distal pulse has to be checked, because at the insertion site, there's a chance of hematoma formation. That hematoma can lead to decreased perfusion to the lower extremities or to the extremity that is giving punctured for insertion of the catheters. They have to check the distal pulse, and patient insertion site or insertion limb should be immobilized for 6 hours, and patient should be on NPO. Following that, within 3 to 4 hours of ICU admission, based on the patient level of consciousness, you have to check for dysphagia. For dysphagia, you can use GUS assessment tool, or if you are having a dedicated dietitian or a speech therapist, they can use the dysphagia assessment. And as the patient is on NPO, definitely we have to give proper fluid to the patient. Usually, as per the guideline, we can give 100 ml NS per hour. If you are giving NS, you have to be a little bit alert based on the patient renal function test. You can administer the normal saline, or if your hospital is having a standardized protocol or guideline, you can follow that. Then medical management. Usually in Indian setting, if you are getting an idea that the patient is having a ischemic stroke, from the emergency department itself, we'll start giving dual platelet and statin. That means ecospirin 300 mg stat, and following that 150 mg once a day. Then tab clopidogrel 75 mg statin once a day, and tab atorvastatin 40 mg statin at night. And after that, if the patient got admitted in the ICU setting, we have to think regarding DVT prophylaxis. In the DVT prophylaxis, usually we use low molecular weight heparin. Then we have to think regarding anti-edema measures and anticonvulsants. Then the surgical management, usually decompressive craniectomy, extraventricular drainage, carotid endarterectomy, and carotid stenting. And nowadays in some advanced centers, they are using the MCA, PCA, bypass and all. Then now it is the era of stem cell management. So some literatures are giving the proper idea that stem cell plays a major role in neuroregeneration and neuroprotection after stroke. So many minimal literatures are available. Intravenous administration of autologous stem cell has played a major role in replacement of the dead neurons. Once this neuroprotection has been attained, patient will be having good functional outcome, and they'll be having minimal disabilities. So management in the ICU, immediately after bringing the patient to the ICU, we have to think regarding FEST protocol. FEST protocol is nothing but usually after thrombolysis, there is a chance of increase in temperature. It's a normal body mechanism. There is a chance of increase in temperature. FE stands for fever management. So we have to maintain the euthermia. For maintaining the euthermia, we can think regarding tepid sponging or any other cold blanket or any other method that is used to control the body temperature. Then we have to think regarding S. Next is S is for sugar management, that is hypoglycemia control or hyperglycemia control. So if the patient is hyperglycemia or hypoglycemia, both are having a bad impact on the patient outcome. If the patient is hyperglycemia, then we have to think regarding insulin therapy, or we can think regarding the administration of drug. And the last S stands for swallowing or dysphagia. So within 3 to 4 hours of ICU admission, you have to alert the speech therapist and they have to do the proper swallowing assessment using their proper assessment scales. Next is the blood pressure control. Usually after the immediate stroke phase, there is a chance of increase in BP. 180 to 180 mg, 180 mm of systolic and 110 mm of diastolic BP is normal. If it is more than 200 or 180 mm of systolic BP, then we have to think regarding the administration of antihypertensive drugs. Along with that, some places they will be giving some IV drugs also. Already, BINSIM has given the protocol for administration of IV labetalol. Then, next is seizure prophylaxis. In the seizure prophylaxis, we can give any new generation of anti-epileptic drugs like levetiracetam or levipil every TDS, so that we can reduce the risk of seizure. If the patient is having a seizure, definitely that will worsen the patient condition. After 24 hours, we can think regarding DVT prophylaxis by using injection low molecular weight heparin, or you can think regarding any pneumatic compression devices to reduce the risk of DVT. And if the patient is in the ICU, definitely the ICU nurse has to continuously observe for any warning signs of DVT. If there any change in the extremity, or if the patient is having any bluish discoloration in or any very minimal pulse rate in the lower extremity, that indicates that the perfusion is not sufficient. So sometimes they can move on to ischemic changes also, limb ischemic changes also. Following that, ICP control measures. For ICP control measures, we can use mannitol, that is the dose is 0.25 to 1 mg per kg body weight. Then nutritional and hydration status assessment and management, that is being done by the dietitian. Then prevention of aspiration pneumonia and hospital acquired infection. In the prevention of aspiration pneumonia, we can think regarding insertion of Ryle's tube or percutaneous endoscopic gastrostomy, so that that risk will be getting avoided. Next is the hospital acquired infection. So usually in the hospital acquired infection, the main thing is that you should be a little bit vigilant, because already patient is having cannula, so there is a chance of phlebitis, or if the patient is in the ICU, at least they should get proper antibiotic coverage also. Then prevention of hospital acquired pressure injury and incontinence associated dermatitis. These are the most common problem that is seen in stroke patients, because they will be having some kind of sensation problem. So at the time of admission, they don't have any skin peeling. But if you are not assessing the Braden score to rule out whether the patient is in a risk of getting pressure injury or not. If you are not assessing, definitely the patient will move on to hospital acquired pressure injury. Following that, in the ICU setting, we usually use stool softener drugs. So there is a chance of loose stools, frequent passage of loose stools that can lead to that means hospital acquired, this means incontinence associated dermatitis. Then prevention of contractures. In the prevention of contractures, within 6 hours of ICU admission, you have to alert the physiotherapy team, so that they can think regarding the proper usage of devices to reduce the contractures as well as the complication associated with stroke. Then there is a risk of fall. So we have to assess the fall risk by using the proper assessment scale, and we have to think regarding the prevention of that particular fall. Suction guideline, vigorous suctioning is not advised in stroke patient. Whenever you are suctioning, you have to maintain the proper suctioning pressure. That is, for adult, we can use 80 to 120 mm of mercury. and early neuro rehabilitation. Early neuro rehabilitation is very, very important. Neuro nurses plays a major role in the rehabilitation of the stroke patients. And moving on to the prevention aspect, we know that alcoholism in Dr. S.K. Narayan from JIPMER has conducted a study regarding prevention of stroke. In that, he has highlighted something. Main thing is most of the stroke patients or stroke victims, they are having the habit of taking alcohol. Some are taking cigarettes daily. Some are obese. They are having an unhealthy diet and lack of physical activity. If any person is having this type of lifestyle changes or any type of this type of problem, definitely they'll move on to diabetes mellitus, hypertension, dyslipidemia, their stands of carotid diseases, coronary artery diseases, valvular heart diseases, and atrial fibrillation. If we want to prevent this stroke, first thing is that lifestyle modification. So whenever we are going for any stroke prevention campaign, we have to stress regarding 5 things. One is they have to stop the alcohol, they have to stop taking the cigarette, they have to reduce their BMI within 24. If they are following unhealthy diet, they have to move on to the proper diet. And if they can consult a dietitian, they can do. And they have to do at least brisk walking exercise daily. So as we know that stroke is a neuro emergency and the time is very, very crucial. A dedicated stroke team is very important in the emergency evaluation and treatment of this patient. And at the time of discharge, remember, we have to educate the patient regarding medication adherence. Because if they are not taking the medication on proper time, there is a chance of recurrence of the stroke, and that will be a life-threatening one. Thank you. Hello?
Yes.
You want to ask anything?
Okay. Thank you, Unnikrishnan, for a good presentation, and it is knowledgeable, and it is with complete of experience that you have shared. It's very good. Do you have any questions regarding this topic? We will take it. One question we have, sir,
Sir.
is there any primary management that can be developed stroke while on the way to healthcare?
See, primary management in the sense, whenever we are bringing the patient to the hospital, if you are bringing the patient in the ambulance, if your particular service provider knows how to rule out whether it is ischemic or hemorrhagic, right? If they found that based on the Cincinnati tool, that means be fast. If anything is there among the 5, if anything one is there, that indicates that patient is having stroke, right? Along with that, they can check the pupillary reaction. If the pupils are a little bit dilated, that indicates that it can be 95% hemorrhagic stroke. In hemorrhagic stroke, we are not supposed to give the antiplatelet drug as well as anticoagulant drug. That can worsen the condition, right? So usually in Indian setting, we don't have any expert emergency medical technicians because they are from this separate fraternity. So main thing is that at the time of admission in the casualty, they can think regarding the administration of antiplatelet drugs and statins.
One more question, Unnikrishnan, you
Okay.
have. One participant.
Sir, can I ask?
Yeah, you can ask.
Good evening, sir.
Good evening.
Sir,
Can you please tell your name, ma'am? So Seti.
Sonika.
Yeah, okay.
Thank you. So I want to ask if the patient came to casualty and after scanning, it's confirmed that it's a stroke. When the patient reached to the ward afterwards, can we take the samples, the basic routine sample, or first we have to thrombolize the patient?
See, already your patient is having a CT report stating that the patient is having an ischemic stroke, right?
Yes, sir.
So whenever that patient is shifting from a hospital, the primary hospital has given the basic treatment. They already initiated the basic treatment and they are already inserted the cannula, right? And you have to ask whether the patient is taking any antiplatelet drugs. Second thing, whenever any hospital is sending a patient to the advanced center, they have to give a proper discharge advice or discharge summary. In the discharge summary, they have to mention which all the drugs they had given to the patient. In that, if it is mentioned that already patient has thrombolized or already patient has given the first IV bolus, you are not supposed to prick the patient again.
Examples. So, but in case if the patient came direct from home to the hospital firstly, then in emergency, not goes to any other hospitals or any other setup. If in case the emergency doctor or the casualty doctor tells to for direct the CT or MRI scan, afterwards I'm asking if the patient is having no IV cannula, no medication is given.
Yeah, usually whenever any person is coming with any warning signs of stroke, right? In the triage itself, they will get an idea that whether this patient is having the signs of ischemic stroke or hemorrhagic stroke. If the patient is having the signs of ischemic stroke, from the admission itself, they have to send the sample. They have to take the samples, right? They have to take the coagulation profile to rule out the bleeding time, clotting time, and TTT time and all. Then RFT has to be done because for inclusion criteria for the administration of thrombolytic drugs, renal function should be normal, liver function should be normal, right? And they should have a normal blood count in the complete hemogram, as well as they should have a normal ESR level. Anything is dearranged, then we can't give the IV thrombolysis. Then we have to think regarding intra-arterial thrombolysis. Two things is that if it is within the window period of 3 hours to 4.5 hours, you can think regarding IV thrombolysis. If it is more than 4.5 hours to 6 hours, then you have to think regarding intra-arterial thrombolysis.
Sir, sorry, but how it's intra-arterial is performed?
See, intra-arterial procedure, you should have an exclusive or comprehensive neuro interventional doctor should be there. It is just like the angioplasty. They will be inserting the catheter through any femoral approach or through radial approach, or in that they usually use the help of float retrievers and all. They usually insert the catheters and they will just aspirate the block, or they can just install the medicine into the blockage area. They have to wait for some time. So as they are giving the drug directly in the artery, in the blockage area, there is a chance of lysis. That's the main thing.
Thank you, sir.
Okay, Unnikrishna, you have one more question. This question asked earlier by Sethi, but there was a network connection from her end. That is, he's just put a comment. I asked the question, I will read it, but due to the network issue, it is not sent. My father has this stroke problem since 2007. Still, sometime if faint problem, what will we do at that time? Should we take him to the hospital, or what we can do?
See, the main thing is that usually stroke patient, they if you are giving proper neuro rehabilitation or stroke rehabilitation, they will be recovering fastly. Second thing is that we have to know what type of stroke it is. If it is a Pontine bleed, then definitely they will be having more disabilities compared with the other stroke. So I am asking which artery is getting involved in the stroke? Any idea?
Means I think she can't connect from voice, so she might be putting again the message.
So first thing is that the stroke has happened in 2007. Now it is more than 14 years, right? In this 14 years, definitely that particular stroke victim or stroke survivor will be having very minimal disabilities, because as they are doing their activities of daily living, they want to lead an independent life. The more they are eager to come out from the stroke, they'll be having more functional disability. They'll be having very functional disabilities. If they are not doing proper physiotherapy, if they are very much lazy to do all the activities, then their disabilities will be more and their functional capacities will be getting limited. Everything is that based on the patient willpower. If you feel that, okay, my life has gone, I'm a stroke survivor, I don't have anything further, my future is getting, then the outcome will be poor. If they have a positive attitude towards stroke, definitely the outcome will be much more better.
Okay, thank you, Unikrishnan. What next question is? It might be going to Bensi. Why urinary catheter is not advisable in stroke patients? It might be a chronic.
First thing is that if it is an hemorrhagic stroke, we have to insert the urinary catheter.
Yeah. Bensi, can you, Unikrishnan might be going to Bensi. So Bensi can please.
Yeah, we don't really encourage to put the urinary catheter because we are trying to give the patient the maximum, promote the independence. Because once we put the urinary catheter, patient will be dependent, to the catheter, and they will get the urinary tract infection, and patient will be more dependent to the catheter. So once patient start to the rehab, patient will be more, dependent and getting the UT and stuff. We won't be able to give a good rehab to the patient. So we're trying to promote the maximum independence and trying to be continent to the patient. That's the main reason we are avoiding the urinary catheter for the stroke patients. In ED, there's a tendency once the patient come into the ED, before even getting to the CT scan, there is a habit of the ED nurses to putting a catheter, getting the ECG, that kind of. So we are, we won't really promote the urinary catheter for the stroke patients.
Okay.
Because for that maximum independence.
Okay. Next question, that is a practical question. Benash Shatab asked, what if a patient suddenly caught stroke while on traveling on wheel? Any simple precautions on that?
Can I hear the question? Can you please repeat the question again?
Yeah, what she want to ask, any precautions to prevent the stroke while driving?
While driving, if the person is having the stroke. See, whenever you are driving, right, if you feel that you are having any weakness, what you will do first? You will stop the vehicle, right?
Yeah.
We'll stop the vehicle because in the warning signs of stroke, it is clearly mentioned that they'll be having facial weakness. Second is arm grip or arm weakness, right?
Yes.
If they want to drive a car or if they want to drive a bike or scooty, definitely they should have a proper coordination with their brain as well as their hand. Already in stroke, hand coordination is getting lost. So they can't move the vehicle more. So they have to stop the vehicle. If they are having a mobile phone in their hand, they can speak this information to a nearby relative, or they can inform to the police person is there, they can inform this to the police person. Nothing more.
Okay.
Because we can't tell that it is stroke or any other thing, right? It can be hypoglycemia, it can be an electrolyte imbalance.
Yes. So it's a late time. It's about 5:10. So I hope there is no other questions regarding this webinar. I'm very happy to see more than 100 participants in Zoom, also more than 700 participants in YouTube. Also, they are watching this webinar, and it is completely experience based. Those who are sharing their knowledge, they have they are well experienced, and so this time I would like to thank Mr. Roy, his TNA president. She came and inaugurated this event, and Dr. Manju Dandapani, she came to unfold the theme of this stroke day, and our academic chair, Dr. Poonam Joshi, and our program coordinator, Smita Das, and moreover, it's a very important guest of us is our speakers, as Bensi from Ireland, and Mr. Unikrishnan from Max Hospital. I would like to thank everyone. One small information: those who are filled the feedback form, they will get certificates online by registered email within 10 days. And this, please watch this complete video in our YouTube channel. And thank you, everyone. So one more question. Unikrishnan, can we take that also?
Yeah.
That thing what is that question? So that question was deleted. Okay, it's asking regarding some dextrose.
Dextrose.
Yeah, but she deleted that question. I think so. I can't see. Okay. So thank you, everyone.
Advanced happy Diwali wishes to everyone.
Yeah, happy Diwali.
Sir, this is
Keep in touch.
आज केशु ने 12:30 नाश्ता किया.
Are contraindicated in stroke patients.
Pardon?
Sir, that question is written as dextrose type fluids are contraindicated in stroke patients.
See, dextrose is not contraindicated in stroke patient if the patient is not having any sign, this thing, diabetes mellitus. If they are having a glucose more than 180 mg per deciliter, we are not supposed to give the IV dextrose. Because if it is more than 180, that means the patient is a non-case of diabetes as per the American Diabetic Association criteria.
Okay, thank you, sir.
So thank you, everyone. Again, thank you, Unikrishnan and Bensi. We are leaving now. Please keep in touch. We will coming with new webinars. Indian Society of Emergency and Cardiac Nurses signing off here. Thank you.